We shall start off with our first speaker, Dr. Shashikant Shethy, and he is going to be talking on special considerations for infantile esotropia. On to you.
Good evening, everyone. My teachers and Dr. Chitra Ramurthy for inviting me for this very great symposium on pediatric ophthalmology and strabismus. I'll be talking on special considerations for infantile esotropia. Basically, congenital esotropia, according to one of the observational study by a group of COA, where they studied infantile esotropia, and they found that most of them, 43% were congenital, 23% they developed within the first 6 months, and we have to differentiate between pseudoesotropia, infantile accommodative esotropia, and patients presenting with congenital fibrosis syndrome. The associations of patients with infantile esotropia is, it is usually the onset will be from birth to 6 months of age. Within the first 2 months, there will be a lot of misalignment will be taking place as the child starts fixing. So patient may, if they have ESO, then they tend to remain esotropic. But if they have EXO, then they usually may become orthotropic over a period of time. And usually they will have cross fixation in patients with idiopathic infantile esotropia. Esotropia presenting after 6 months of age is basically acute onset esotropia. And they can have 50 to 90% of patients can have dissociated vertical deviations. 70% of them may have inferior oblique overactions. They may have mild or moderate amblyopia. And usually they will have non-significant hyperopia, where the hypermetropia is usually less than 2 diopters. That is very important. Asymmetric in OKM readings, that is very important. They will have nasotemporal asymmetry, which will persist in adult age also. And they can have head tilt to the fixating eye if they have DVD in that eye, which is the eye which is fixing. But they can have a contralateral tilt to the opposite side if they develop superrectus contracture of the fixing eye. Infantile esotropia usually less than 6 months. We need to differentiate between early accommodative infantile esotropia, where patient may have high hyperopia. We need to differentiate between ESO-DRS, Mebius syndrome, where they can have bilateral 6-nerve with bilateral facial nerve palsy. Then 6-nerve palsy. Usually, Jampolsky feels that 6-nerve palsy doesn't exist. It's basically most of the patients who are diagnosed to have congenital 6-nerve palsy usually have Duane's retraction syndrome, because 30% of Duane's retraction syndrome patients may not have retraction or upshoot or downshoot. And we need to differentiate between nystagmus blockade syndrome, which can be diagnosed by eye movement recordings. The earlier etiology for infantile esotropia was suspected to be in visual cortex. But now the recent studies by Dr. Brodsky and their group, they get a newer concept of corticomesencephalic cerebellar disorder, which says that the subcortex pathway, which are actually disappear, the reflexes disappear as the child is born, but they tend to remain functional in this patient. The subcortical layers predominate over the cortex, and this is responsible what he feels for the infantile esotropia. And then he has told the role of accessory optic system and the role of cerebellum, which also can play a role in development of infantile esotropia. So patch test is very important. Either you can use the patch or a prism in front of the eye, in one of the eye. And then the colorful toy is shown in the temporal field of the fixing eye, and it actually forces the infant to abduct the uncovered eye. And so you can rule out the limitation of abduction, and also you can simultaneously look for inferior oblique overaction in the other eye if the prisms are used. So when we need to operate these patients, how early? So there were multiple studies done by Hirako, Shirabe, which are published in British Journal of Ophthalmology. it was concluded that early surgery in infantile esotropia is beneficial to achieve binocular visual function, but it is necessary to confirm a stable angle of deviation, accurate pre-operative evaluation, and to maintain good post-operative eye alignment throughout the follow-up period. This was the results from that study. And there was one more study by Higashi and their group, which looked at the stereopsis outcome in the timing of surgical alignment in infantile esotropia, when they found that the patient demonstrated binocular vision at near in 96% of patients, and stereopsis in 77% in very early age group, less than 7 months of age. And the reasons they said for the early surgeries for a better binocular vision, to have better binocular visual field of vision, improvement of visual behavior, better appearance for the parents, to have a child will look similar to others, and early surgery they felt that decreases the chance of dissociated vertical deviation, which was study done by Yagasaki and their group. And reasons for late surgery, this is a different group who says early surgery there's a possibility of difficulty in examining strabismus in these patients, and their concerns regarding general anesthesia at a very small age. There can be spontaneous remission of squint post early surgery, and there's a poor outcome prediction. There will be fear of overcorrection, undercorrection, and need for multiple surgeries. So this is very important. Sometimes we might see patient who comes with the DVD with exotropia. So we have to rule out spontaneous consecutive exotropia. That is very common in these patients who have infantile exotropia, who have very variable angle deviations, and they can have a high hyperopia of +5 and around that +5 to +3, average of +3 to +5. And they can have delayed milestones. They have lack of binocular single vision, which can predispose them to spontaneous consecutive exotropia. If you see a child who has exo with DVD, we need to look at the FAT scans. FAT scans are nothing but family album tomography scans to look for if the patient had esotropia earlier and which has spontaneously drifted into exotropia. This is a paper done by Julie D. Senior, which is published in Strabismus 2009, where they looked at 14 patients over 4 years period, and the onset of esotropia was 24 months or less, and they had a hyperopia of +5 and the mean spherical equivalent of 3. Most of these patients have they lack binocular single vision, and they are variable esotropia with no single consistent finding. So what are the surgical options available to treat this type of patient? There's bimedial recession, recess resect, Botox augmented surgery, Botox, Y split of medial rectus, and other surgeries. So a lot of studies, they looked at bimedial recession, and many of the authors felt that bimedial recession of 7 mm is safer. But there was other group which looked at recess resect, and they also found that the results are similar for both bimedial recess as well as recess resect procedure. And if the angle is very large, like more than 70% diopters of esotropia, then they used to have Botox augmented recession of medial rectus with the resection of one lateral rectus. So they injected Botox similarly in both the medial rectus, like 1.25 international units or 2.5 international units into one medial rectus combined with recession. Or we can give Botox in the early infantile phase by 3rd month or 4th month. And the repeat Botox was given after 6 to 7 months. And they found that 30% of their patients over a period of time improved. But eventually, 70 to 80% of their patients required surgery later on.
Sir, you have 1 minute remaining.
Yeah, so this was the Cochrane review done by Shimons et al. And they looked at infantile esotropia patients, and it was concluded selection of either BMR or RR was the surgeon's personal preference. And they found the BMR was very effective in correcting infantile esotropia. Talun et al. Found that BMR to be simple, faster, and less traumatic, leaving the lateral rectus intact for patients who require a second surgery in deviations smaller than 50 prism diopters. So summary, When early surgery is still preferred but with stable angle measurements. Why binocular stereopsis does matter. BMR remains to be the conventional technique. A large recession 6 to 7 millimeters shows good results. Botox augmented surgery has proved to be promising but needs more prospective comparative studies to prove the results. Y-split recessions along with middle rectus recession and the results are comparable to BMR. And in patients who have inferior oblique overaction, Kushner thought that patients' muscles which overact, but they are inelastic, they are not tight muscles. And recommendations were to anthropose this muscle, then recession, because if you do the anthroposition, then it takes care of the DVD which can develop later on. So what patients with early surgery have better stereopsis, but amblyopia management has to be continued after the surgery. And patients with inferior oblique and DVD have an average higher number of surgeries and prognosis poorer compared to patients with only infantile esotropia. And to add to it, there was a large study which looked at the long-term effect of patients who didn't undergo surgery for infantile esotropia, and they found that the chance of developing amblyopia was less in those patients when the patient underwent surgery. So patients who underwent surgery, chance of developing amblyopia was higher because the one eye developed dominance and they developed amblyopia in the other eye. So they found that amblyopia was less in patients who didn't undergo surgery in long-term studies of patients of infantile esotropia. Thank you.
Thank you very much, Dr. Shashikant. It was something even a non-pediatric surgeon could understand. It was so simply brought out. But how early is your early surgery?
By 7 months.
7 months. And it's sort of a common consensus amongst all of you, or there is a variation amidst pediatric ophthalmologists on that?
We need to ask the panel. Rohit can throw some light.
Yes, Dr. Rohit. Dr. Rohit is not there. Dr. Vijay Lakshmi.
Vijay, ma'am, do you always operate around 7 months of age, ma'am, or you wait for a little longer? We, as personally and at Shankar Nethralaya, I push the surgeries close to the age of 1, mainly for 2 reasons. One, we kind of bring out all the associated, DVD, infantile, inferior oblique overactions. Sometimes it's very difficult to assess the presence of DVD and inferior oblique overactions in children around that age of 7 months, 8 months age. And second thing is cooperation, the angle measurement, all that is a little more challenging in that age. So kind of around the age of 12 months or so, we are able to elicit these secondary issues of inferior oblique overactions, etc. in those children, where if you tackle it at the first sitting, the consecutive exotropia, all that developing is probably slightly better. That is our experience.
Oh, good. I have one question before Dr. Kalevani can take over the whole thing. How do you tackle the consecutives which can occur, and how do you avoid it? Can you? I would want Dr. Vijay Lakshmi. Is she there? She's not there.
She's there, yes. But her video
Can you unmute yourself, Dr. Vijay Lakshmi? Can you unmute yourself? Yes. Yeah.
See, as Kavita said, I also try to wait till 12 months, but very rarely, very large angle deviations, we can go ahead. If the patient's parents persist, we can go ahead. But the consecutive deviations are still possible if you are not confirming your findings, or you are missing the pattern deviations or a DVD, you will definitely end up with the consecutive deviations. But consecutive deviations, if you are a little bit under-correcting when you are doing it, definitely, and you are confident about your findings, that can be avoided. Because certain peripheral fusion you can achieve if you are in between that 5 prisms or 8 prisms. So you can definitely avoid. Going in consecutive XT for infidelity is a little bit rare in our experiences, except in patients where they have brain problems like CP or PVL patients, where you are in a hurry to do the surgery. Those patients, we should wait not early, at least 2-3 years, because consecutive XTs, spontaneous consecutiveness is more common in those individuals. If we could avoid those and then do unindicated cases, this can be avoided most of the time.
Yes, Dr.
The reasons quoted, one of the main reasons that is quoted for consecutive exotropia is they say that medial rectus slippage when on table when they find during re-surgeries. And we recently discussed an article where they used permanent sutures instead of absorbable sutures for medial rectus recessions. So Dr. Rohit, do you have any inputs on this? Does it prevent, as that paper is supposed to claim?
So, actually very, I mean, I would say that our initial pre-op, we do have, in fact, sometimes feel that little consecutive may actually be beneficial, which is the basic experience for infantile esotropias. And I have not, I mean, I would say I don't have that much. I mean, we do have a few consecutive exos, but I have no experience on using non-absorbable. So I would say I would continue, because children, the muscle should stick very, very quickly. You would have a very good and firm response from the muscles for sticking. So, I mean, I would not use a non-absorbable for a child.
Right.
Also, Kavita, now people talk about large recessions, 6 millimeters, 7 millimeters, that we were not, at least I was not doing. 5.5 was my maximum in a child about 12 months old or 1 year old. Very rarely you may go up to 6, but very, very rarely in paretic strabismus, other etiologies, not for infantile ET. That also may be another reason that we don't see much consecutive deviations.
Yes, ma'am.
Yeah. The other important thing to remember is to measure it from the limbus. In less than 1 year old child, the anterior segment development is not complete. So as ma'am says, over time, you will have the anterior segment developing. And if you insert your muscle at 6 or beyond, then you are actually going to place it retroequatorially. That could be one of the reasons why they may be finding the muscle is much far more posterior than they would have planned. So that is one of the conditions I could believe that may be responsible, because I would say it's extremely unlikely that in a child, a muscle should slip, unless it slips primarily during surgery because of, not opening up or something. But a late, stretching of the scar or late dehiscence of the wound is very unlikely, because you would have a good, strong reaction in a child as compared to an adult. You would have issues maybe in adult, but in a child. So I think the point ma'am is pointing out is very, very important, because in the development, the anterior segment is not full developed. The insertion of the original medial rectus may not be exactly 5.5 millimeters from the limbus. So measure it when you measure, mark where the muscle should have been, and then mark your recessions. And as ma'am says, very rarely I have gone to 6, but almost never in an infant. Only in children beyond 1 year of age would I go at 6 mm recession. Otherwise, my upper limit for less than 1 year old child would be 5.5 millimeters.
Yes, sir. Thank you, sir. And another point probably is sometimes some of these children have little low hyperopia, which we may initially kind of watch, not give glasses, but after surgery, when we see a small esotropia and a little hyperopia, it's better to follow them very crucially and prescribe that glasses. Probably that is again another thing that we find in all the small subset of these children developing a little bit accommodative type of esotropia after 1 or 2 years of surgery for infantile esotropia.
Absolutely. The thing would be that a child with infantile esotropia would have a poor fusional reserve. And a child would then be at risk of developing accommodative esotropia if he has a modest or higher hyperopia uncorrected, because he would try to accommodate, and with insufficient fusional reserve, he may develop the accommodative esotropia. And many studies have actually pointed out that children with infantile esotropia should be followed up, because they can over time develop accommodative esotropia and the strabismus precipitating because of that. So they need at least not full correction, but appropriate correction for their hyperopic refractive error.
Actually, Jampolsky puts it as surgical orthoptics. He says in a very good, excellent article in, I think, David Taylor, he had mentioned surgical orthoptics, where he says if the patient has good alternate fixation, no hyperopia, no amblyopia, making them little exo stimulates their fusion.
Absolutely.
And then they come to orthotropia. That is what he writes in his.
Exactly. That's what I said, that we would always not mind a little overcorrection, and if required in the initial period, undercorrect the hyperopia, so that the patient actually develops an increase in the fusional reserve. He's attempting to fuse, and we have good fusional convergence. So it would stimulate, bifoveal stimulation would be there, and he would stimulate a fusion. So that's why even in fact, you would say Botox studies, although I don't use Botox, but Botox studies also say that the endpoint of botulinum toxin should be a little overcorrection in the initial post-op period, because subsequently they will get aligned. So a little residual ESO would be a less than optimal result.
Dr. Surendran, would you like to add something before we go on to your talk?
Yeah, I think we have done a study, I think sometime in 90s, I think, wherein when you had operated between 1 year to 2 years, I think the binocular vision was achieved only in 5% of the cases as the children grew, because 1 age, 2 age, you cannot assess their binocular vision. And I think Jayendra Shankaracharya's brother's own granddaughter, he requested me, he actually made me to operate a 6 months child and congenital esotropia. And I suspected that one eye was squinting more often than the other eye. And ultimately it turned out to be an eccentric fixation and very dense amblyopia. So 6 months child, I operated infantile esotropia, which turned out to be the fixation was somewhere very paramacular, eccentric fixation. So I think it is still controversial. When the Kavita protocol we all follow. Tomorrow I'm doing a 1 year case, but I'm doing a bimedial recession 7 millimeters. 7 millimeters, I tend to differ with Dr. Vijay Lakshmi.
Yes.
That if I think I'm not able to reach a 7 millimeter, I put it on the hemi hangback. And I think I have had excellent results. Another we don't see VIP as a pediatric ophthalmologist. So another VIP was this Muthaiya Muralidharan's brother's child. I operated bimedial recession, 1 year child. Beautiful orthophoria and fusion also is there. The child has grown now.